which anyone, on average, what one person would do in terms of infecting others. And at the moment, that our naught values somewhere between 2 to 3. And the aim is to get that below 1, at which time things start to then decrease.
And just to be clear, that's not 2 to 3 weeks. That would take a bit longer than 2 to 3 weeks?
That will take longer, yes.
What would be a sort of hope there?
Difficult to get a very accurate handle on that, and that's where monitoring becomes incredibly important. So I think as we enter this next phase, and having made these very significant interventions, it's going to be really, really important that we can get the good data to monitor the effects. That's important for 2 reasons. One is we might need to do more. And I've been very clear from the beginning, there's a whole range of things that we need to look at. All of them are on the table, that we might need to do more. And of course, we might also, at some point, need to back off. We will need to back off at some point. We need to be able to monitor, well, what's the consequence of backing off?
But just appreciate this is the upside and there are no certainties in this. But if yesterday's announcement bears the fruit that you're hoping, the total number of deaths, rather than being in the hundreds of thousands, could potentially get below 20,000, which is still a huge number of deaths, but is nonetheless a much better picture than many might have feared.
That is the hope, that we can get it down to that. And to put that into perspective, every year in seasonal flu, the number of deaths is thought to be about 8,000 excess deaths. So if we can get this down to numbers 20,000 and below, that's a good outcome in terms of where we would hope to get to with this outbreak. But I mean, it's still horrible. I mean, that's still an enormous number of deaths, and it's an enormous pressure on the health service. And having spent 20 years as an NHS consultant as well as an academic, you know, I know exactly what that looks and feels like.
And just before I bring my colleague in, just one final question about what we have come to understand about the disease. Most people understand that the people who are at risk are either people with a long-term condition or older people. But in the Netherlands, we understand half the COVID-19 patients in intensive care are under 50, including one 16-year-old. Have we had any deaths in the UK from people who are young and without long-term conditions?
I don't have all of the clinical information because that's privy to the health department, NHS, and the chief medical officer. So that's really a question for them. But it is obviously a very important thing. Most of the deaths, I know this for sure, the vast majority of the deaths in this country are people who are elderly, who've got pre-existing conditions. I can't tell you, because I don't know, whether there are any exceptions to that.
And are you aware of any doctors or nurses who are currently in intensive care because they've picked up the virus from patients?
Again, I'm not privy to that sort of information. That's something, and I know the CMO is being very careful, rightly, about protecting confidentiality of patients. But I would say that the one of the points maybe underlying the question, which I think is important, is these viral infections can adapt and change as we go along, and we must keep an eye on everything from clinical picture through to outcomes through to different ages to make sure that we're always dealing with what we think we're dealing with.
Luke?
Just in reference to the questions over the percentages you gave, what's the confidence interval you're using on those? Because if it's nice and narrow, then it doesn't matter.
Very wide.
Can you give us a ballpark of therefore where you're going with?
Well, so the range, for example, for the first measure of case isolation was between 15 to 25, I think. And even that, I think, you would take as a sort of a model, but not a precise estimate. So I think all of the confidence intervals in these things are quite wide.
Thank you. In terms of the monitoring side, you've mentioned that. With the change in policy around testing, can you explain how you expect to monitor if we're not doing as much testing? I think people struggle with trying to see that picture.
At the moment, the UK has done something like 44,000 tests, which I think is in the top 3 or 4 countries in terms of testing, and Public Health England have got a capacity of about 4,000 or so per day. That clearly is not going to be enough going forward, and one of the recommendations from SAGE is that we really do need to get our testing in the right position to make sure that we can monitor this effectively. At the moment, the priority for testing is patients in hospital in intensive care units, those with respiratory illnesses in hospital and pneumonias in particular, isolated cluster outbreaks to make sure that we can understand what's happening there, and the GP surveillance systems trying to get a handle on what's going on in the community. As the capacity ramps up, and there's a very big effort going on to try and ramp that up, that will be extended to other groups, and ideally you get that very wide. The second form of testing that I think is going to be incredibly important is serology testing. So looking for antibodies of people who've had this infection. And the reason that that's so important is all we can do at the moment is detect somebody who's got active virus that they're shedding. And there's some evidence that if you're asymptomatic and you're infected, the test isn't at all sensitive. So we're not even nobody's really able to pick up the asymptomatic people very easily. So with an antibody test, we'd have a much, much better handle on the proportion of people who are asymptomatic, the true number who've had it in the community already, and I think we'll get a better handle on what happened in other countries, in China and Italy. It would change a lot if we could understand that.
Okay. I was just going to say, thank you for that. One of the groups you missed on that, and my colleagues in primary care and indeed the hospital are most concerned, is they're having to isolate without any symptoms, and suddenly 3, 4, 5, 6 members of staff drop out of a surgery. Their argument is, why aren't we being tested? I want to get back out there and help. It would help a lot. What do you say to them in answer to that question? Part sounds like capacity, but is there any other reason around that, and what can we do to rectify that?
I think the next group of people that I know, PHE, and to check with the CMO to make sure that this is exactly where they want to go, is to try and get to sort of key workers to make sure that they're tested, and obviously healthcare workers would be absolutely there. So I think as the capacity ramps up, that's where you'd go next to make sure you can do that, and I think that is the plan.
And with around that, it'd be useful to know most people will recover. Let's not forget that this is flu for most people.
Yep.
Could you talk us through how quickly they recover, when they could return to work, and then also that cohort, and if you've got any ideas? It seems like you have a response phase, you start to improve, your antibodies fire off, and you get this cytokine release that causes an ARDS, so your respiratory problems, and that's when people crash. Is there any indication of how you're spotting? Do those people have a sign? Is there a test for them? So there's two parts to that question.
Yeah. So you're right, and very early on, I spoke to colleagues that I've known and worked with in Singapore right early in their outbreak, and it was clear from them that there was this 2 phases of illness. The vast majority of people, as you say, get a viral illness which gets better, so that by 7 days they're feeling better, often by 5 days they're feeling better. Some of them go on to get this second phase, which is the immune reaction. And that immune reaction seems to kick in at around 5 days. It's characterised by shortness of breath, failure to get better from the first round, and then a deterioration. It's important that this isn't, at that stage, due to active viral replication, so much as the body's response to it. Yeah. And so, the idea that antivirals are going to work then is probably wrong. They might work very early on. What are the features that make people more likely to be in that phase? Some evidence that it's initial dose of exposure, which is why healthcare workers potentially stood a risk at the beginning if they were being exposed to very large doses, and pre-existing diseases and age, which presumably is a surrogate for pre-existing diseases as well. So that's sort of at high level what we know about this at the moment, and it does have quite big implications for how we think about treatments.
And could you just explain for the public then, for the people who are getting better, how do they develop an immunity, and when can they return back to work? So if they do their 5 days, they're feeling better, are they able to go back out into the workforce and they're protected so that they can carry on working?
The vast majority of people seem to stop having significant viral shedding around 7 days. Okay. Some may go on a bit longer. That's why the 7-day isolation period was recommended for individual cases. Some may go on a little bit longer, but for the vast majority of people, the viral shedding has decreases quite rapidly after about 4 or 5 days.
Can I just go back to the comments you made about testing? Because I think there is quite a lot of confusion about this. So first of all, the words of Dr. Tedros, the Director General of the World Health Organization. He said, you can't fight a virus if you don't know where it is. Find, isolate, test and treat every case to break the chains of transmission. But on Friday, we stopped community testing for people with mild symptoms. And Chris Whitty said people who were in the community with a fever or cough do not usually need testing. And a GP who, for example, self-isolates because his daughter has a fever is not now able to get a test. So are we now saying that it is the priority to test as many people as possible, and that what we did on Friday was an absolutely temporary measure, and we intend to reintroduce community testing as soon as possible?
I think what Chris said, or I think what he meant, if he didn't, I think it is what he said as well, was that that's what we have to do with the capacity we've got. We need to use the testing in the right place at the moment. And we simply don't have mass testing available for the population now. And there's a big effort going on to try to get that in place as quickly as possible to be able to manage this. And people are producing all sorts of tests which may be much more readily applicable in the wide community. Those are all being looked at by Public Health England to decide which ones really work and how they might be thought about getting those out. But the point I think Chris was making, and he'll obviously speak for himself, but the point I think he's making is that in a situation where you've got a capacity to do a certain number of tests, the priority should be the areas that I mentioned.
But how it came across was that there was a change in approach and that we were focusing our testing efforts from now on hospital and hospital cases. But I think what you're saying is that's not the case, and it is absolutely the intention as we ramp up our testing capability that we will go back to testing in the community. Is that the case?
Well, what I can tell you, and remember I am the government's chief scientific advisor, so I'm advising, and SAGE advises, is that we need to ramp up testing for all the reasons that you've mentioned. There are two things that are critical: ramping up testing and making sure we have great data flows. Those two things are very, very important in how we manage this, for both the interventions and, as I said, for removing the interventions.
So if I just look at some other countries that have taken the suppression model that was published in the Imperial paper this morning, which we're now following, the one that most people think has had the greatest success is Korea. And they actually had a more serious situation than us because they had a super spreader. But if you look at their testing capacity per head of population, they're testing 10 times more people. So is that the kind of scale that we are looking at, sort of not just increasing it, I think, from 5,000 to 10,000 a day, but a massive increase?
I think we need a big increase in testing.
Right.
And that's what I'm pushing for very hard. And everyone's working hard to try and make that happen. And the other thing is, I think what you don't want is everybody coming to the hospital to be tested. I mean, that's the worst possible thing. So the quicker we can get to something that looks like a true community-based test that people can do easily, the better.
And do you have any sense of timescales on that? Because I think a lot of people are concerned that when we're not testing in the community, we won't have the data to actually know what the spread of the disease is.
First thing to say is the measures that have been put into place, so case isolation and now whole household quarantine, are the measures you would take anyway. So they are the things, if you like, the potential downside of what we're doing at the moment is we're putting people into whole household quarantine who might not have coronavirus. And so they may have to do it more than once. But we're doing the right thing if you have got coronavirus, and we're doing it for the whole family. So in terms of the actions, it doesn't matter. In terms of the speed of test, there are tests now. Lots of people claim to have tests, and there are obviously very good laboratory tests which can be done. There is a lot of work going on at the moment, I know, in Public Health England, NHS and DHSC to select which tests we should go for and how that can be ramped up, possibly, and I think quite likely, by the private sector, so we can get things out there fast on the community side, having the other part of the testing really controlled by Public Health England for the hospital and the other bits that need to be done.
And then just a couple of brief final ones from me in this section. If we look at some of the countries that have followed the suppression approach successfully, and I think Taiwan is another one alongside South Korea, one of the things that is very striking is their use of mobile phone technology to follow someone who turns positive for the virus and then trace all the mobile phones that have been near that person. Now, obviously, there are civil liberties implications that need to be worked through, but if that was shown to reduce lives by increasing the speed at which you isolate potential cases, as a scientist, is that something you would consider recommending?
I think that would have been an absolutely brilliant thing to have had in January. So at the beginning, that sort of approach makes total sense. It may well have utility later on, and it may well have utility as you go to a situation where you get the R0 down and then you want to sort of see what happens when you release. So I think those technologies do have certainly a place that needs to be looked at carefully and implemented. And I know, again, people are working very hard on that sort of approach, and as you're probably aware, I think that was used quite extensively also in China through the WeChat app that they have.
And finally, just from me, could I just ask you a question in your capacity as a former NHS consultant and not just chief scientific advisor? Obviously, and Luke alluded to this, staff can't look after patients if they themselves are ill. And a lot of staff are worried about the lack of protective clothing, protective equipment. And I just wanted to read you, here's a comment from one doctor who is currently treating coronavirus patients in a major UK hospital, and he says, 1 week ago I was wearing full personal protective equipment. Now we've been told not to bother with any of that, contradicting WHO guidance. I'm terrified. I can't bear the thought of infecting other patients with a disease that could kill them. What's your reaction to that, given our determination to bring down mortality rates?
Well, I think that is a question that really needs to go to the NHS as they think about how they organise the response to this. I think it is important that we get the proportionality right in terms of where protective equipment's needed and where it's not, because one of the things that is a risk is that if we go to the wrong place on protective equipment, actually it hampers all sorts of other parts of healthcare delivery. So I don't think that's really a question that I'm in a position to answer, but I think it is one that the NHS could answer.
Okay, thank you. Dean.
Thank you. Thank you, Sir Patrick, for being here today. I have two broad areas of question. One is around data and one is around schools. On the data side of things, I've had a lot of scientists, a former scientist myself, asking me why we aren't releasing open data on everything we possibly can, given the number of brilliant brains, not just in academia, but also in business, who are, for use a phrase someone shared with me the other day, chomping at the bit to try and help and look at the modelling. I was just interested to get your view on why that hasn't happened and what will be happening on that front.
I think there may be two bits to that question. In terms of the data, I think the data is being released by PHE and NHS, and those are the data which everybody are using, and they're data collected from around the world. And then there's a second question about the modelling.
Yes.
The modelling, clearly it's been rather fast moving. We've had all sorts of different modelling things that have gone along, and then Neil Ferguson released his paper yesterday, and we're releasing the modelling that's been done and the various other parts of the science input to SAGE this week to try and get that out in the public domain. But the data, I think in terms of the multiple brains on it, it's the data access which is important, and that data access needs to work well, it needs to be open, it needs to allow people to sort of crunch the numbers and come up with the answers that they come up with. The models and the codes will be made public by SAGE and by the academic groups that are doing it. I mean, it's not a government organisation that's doing it, it's the academic groups that are doing the modelling, and that will be released.
And in terms of that, is there just one of the other questions I've had, and this might be a naive question, but is the modelling that we're using in the UK the same modelling that's being used throughout the world, that's given it's a global pandemic? Is everyone using the same approach? And if so, why in some cases do we seem to be making slightly different decisions from other countries?
I think modellers are using, as always, they use different models depending on what they think are the most important variables to put in and how they treat those. I do know that the modellers that we use are being used by others as well, and in quite a lot of demand, so that other countries have either used the modelling that's been done here or asked the modellers to be involved in things. So I don't think there's any great difference in terms of how modellers have approached this, but some countries have got fewer modellers and some have got more, and the UK happens to be a country which has got extremely strong science right the way across the board, including in modelling.
And regarding that modelling side of things, we've seen during elections in so many different areas that data is used across both for predicting disease and so on, but also can be used to identify vulnerable areas, vulnerable people, perhaps older people in certain areas. Is there a plan to start to look at this in a slightly different way, where we can predict where potential vulnerable people might be, so that we can ensure that volunteer networks and support is given to them ahead of time?
I think that I know that, for example, GHSC are using the data they've got to try and understand where the most vulnerable people are, in order to make sure they get the specific advice they need. And so I think that will happen, I guess, within the department and within the NHS. I think the other question for modelling going forward is to what extent it can help understand where capacity is being reached, and where therefore there are more stringent interventions that might need to take place in one area or another in order to manage this. And I think this is going to have to be an actively managed process to keep on top of it, which means I come back to my 2 points, that testing and data flows are going to be critical to get this right.
And thank you. And on the school side of things, because this seems to be the biggest topic in many MPs' casework and inboxes, could you give I understand that closing schools might mean that children then have to be looked after by grandparents and so on. But what I'm hearing is that this is already happening, but on a lower level already. For example, I was told a story just this week where one school is testing the temperature of children as they walk in the door. If their temperature is too high, the parent then has to literally find somewhere for them to be looked after. In many cases, that is grandparents. So could you just give a really clear view on why schools aren't closing now, why we're doing it differently from other countries, which seem to be quite commonly closing schools, and if schools are to be closed, what the plans are around that?
When we looked at all of the interventions, we looked at the ones that had the biggest impact first, albeit with the variability that we talked about, and those that have less effect. And school closing was definitely a bit lower down the list than some of the ones that we've announced. It doesn't mean it doesn't do anything. It would have an effect. But it has all sorts of complicated effects as well, including the one that you mentioned of potentially leading to children being with grandparents and so on, and of course also causing an enormous problem not just for the workforce generally, but for the workforce in the NHS as well. So it's a complicated one, and all I can do is give the sort of science advice on that in terms of the effect. I think as you look across the world, for example, Singapore hasn't closed schools. It's introduced some different measures in schools. Taiwan, I think, didn't close schools in managing this. So there's been a variability across the world in terms of school closures and whether that's been part of the approach or not. It's absolutely on the table, as the whole suite of measures are. The evidence base is there to suggest where it might work and where it doesn't work. And decisions will, I'm sure, be made at the time that they need to be made around school closures, which is one of the things, one of the levers to pull to try to get on top of this at the right time. But I say it's not without quite complex consequences.
Yeah. And just on that, just two more pretty brief questions, if that's okay. One is around school children. I have a daughter myself. A lot of kids are talking around this. They're not, they're not ignorant of the situation. And one of the concerns also is around mental health. around children, how they're being taught about this in schools. They're worried that they're going to give their grandparents something that could potentially harm them. Is there any discussion around mental health around this? Of course, physical health is absolutely key, but mental health and the concern of the repercussions of this over the coming months and years could be quite high.
I think that's one of the big worries. I mean, we need to remember that the health service is going to be under pressure during this process, and there will be the direct illnesses and tragic outcomes relating to the virus. There'll be the indirect, due to the fact that other people may not be able to get the care at the time that they need, and there will be the consequences on things like loneliness, on people feeling isolated, on people not being able to get enough exercise and the other things they might want to do to keep themselves healthy. And mental health is definitely part of that. So I don't think, and that's why, when we look at the measures that were announced yesterday, that is a very substantial set of measures with a lot of consequences, and it's why also this is something for all of us. It's our ability as a society to help each other during this time, which is going to be incredibly important, and I think that's where we will see a lot of people wanting to help in order to try and get through this. But it's not an easy situation, and it's going to go on for some time.
And very finally and very briefly, in terms of schools, I imagine you must have talked at some point about schools potentially closing.
Yes.
If that were to be advised, do you foresee it being an overnight decision, in which case tomorrow morning children won't be going to school, or would it be a staggered thing, so teachers, parents and children get a chance to adjust and know what their plans will be, so that kids aren't just given to grandparents, as it were?
I think that's a decision for ministers to take as to how they would make a decision about closing schools and in what way they would choose to do it.
Okay. Thank you.
Paul.
Hello, thanks for appearing before the committee today. Just on schools, I've just got a couple of questions just from the exchange you had there. I've had a number of inquiries from teachers who have emailed me about the risks that they feel they have about their exposure to the virus. What would you say to them?
I think all of us, of course, and that's one of the reasons we have given the advice on the measures we have, want to try and reduce the transmission, and that's the social distancing measures. There will be groups of teachers and others who are particularly at risk potentially, and I know this is something that the CMO is looking at hard and thinking about the right advice for those people. I think for everyone in the public sector working, and those continuing to work in aspects of the private sector as well, clearly the more we're going out and about, we do all carry some risk of catching this. To go back though to the point that was raised earlier, for most people this is a mild illness, and we just need to remember that for the vast majority this is a mild illness. So I think advice around specific measures for vulnerable groups, those most at risk, is what NHS and DHSC are producing.
Yeah, and I've also noted that there's been some talk of advice given to those who are pregnant. What would you also say to those, and I declare an interest in the sense that my daughter is just 12 weeks old, but to mothers and carers for very, very young children, babies?
I don't want to dodge the question so much, say that's really a question for the Chief Medical Officer. Okay. I mean, I know I'm a doctor, but no, I haven't practiced for a long time, and it's not, I don't want to be giving advice that's really the thing that the CMO and the NHS should be giving. Okay,
that's fair enough. Is the government engaging with those scientists that disagree with your plans?
Oh, completely. I mean, absolutely. If you think SAGE and the way SAGE works is a cosy consensus of agreeing scientists, you would be very mistaken. It is a lively, robust discussion with multiple inputs, and we don't try to try and get everybody saying exactly the same thing. The idea is to look at the evidence, come up with the answers as best we can. There are subgroups that work and feed into SAGE, and the membership of SAGE, I should say, changes depending on what we're discussing. So it's not as though it's the same group of people that always discuss all the topics. There are members that come for specific items.
And you made it clear that your role was to advise. How much do you believe that the current strategy that's being driven by scientific evidence, and how much by behavioural science, and how much perhaps by economic interest?
Oh, I think the advice that we've given from SAGE, which is based on modelling, virology, clinical, behavioural science, actually even other areas of science as well, that goes to the government, has been really carefully listened to and has not been in any way, from our perspective, overlain with economic considerations as a reason to change the advice. Okay. So it's very straight advice. We're interested in two things. We're interested in saving lives and protecting the most vulnerable. And that's been the driving force that will continue in all of our outputs.
And just finally, other than what we've seen in terms of the regular conferences, I think daily conferences we're going to see from now on, what strategies are there in place to ensure effective information is given to the public and other organisations on the essentials of the plan? Yeah,
again, that's not really a science question in the sense that I can't, I'm not in charge of the communications of it, but no, sure. I do think it's critically important. I mean, it's very obvious that this is complicated, it's frightening. People don't know what to do sometimes, and therefore the clarity and the ability to keep repeating the same thing in a way that people can understand, I think, is crucially important. And all of the behavioural science would suggest that we've got to get the transparency right, we've got to get the communication right, we've got to trust that actually people want to know things, they want to know about this, and they want to be able to be empowered to make their own decisions on this. And I think those are some of the key things in terms of how we communicate this.
Okay. Thank you. Laura.
Thank you. There were some very serious measures which were imposed yesterday. You mentioned earlier that what happens when you release them is the big unknown. And you also said that we've got to look at what is the consequence of backing off when we think about taking them off. Can you just talk us through what the process is for these measures being lifted and when you think that might happen?
Well, we're just at the start of implementing them, so I think we're nowhere near talking about releasing them. They're about making sure we do them properly. And as I said yesterday, and I've said again here, there may be other things that needed to be added, and we've talked about one of them here. There may be others. When we get to the stage where we've got the outbreak down to a level where we know we can keep it below the NHS capacity, which is the aim, and when we're happy that that can really be maintained properly, that's the time to start talking about how you might release it. And there are various ways that you could think about that in terms of backing off a bit, seeing what happens, putting things back. And that, I think, is the sort of approach that might be necessary in due course, but we're not there.
Do you have a figure in terms of that NHS capacity that you're working to?
Well, the NHS capacity will come from the NHS, so they will provide the figures as to what their capacity is, and then the models can obviously, and the data streams can flow into that to say, well, where are we against that capacity?
Fine, so there's not a number now that you have that you know will be the case, that is the capacity that when you think you can manage that number, you will lift the restrictions?
Well, so there are two bits to this. That there's the infection itself and how common that is and how much that's going to increase or decrease. Yep. And then there's the capacity of the NHS, which they're working on incredibly hard to try and increase. And so that number's moving, both numbers are moving, and obviously both of those numbers are the ones you need to keep an eye on as you think about when you might be at a stage when you can think about backing off.
There are some people that are suggesting that these measures may last 18 months. Is that something that you think might be credible or not?
18?
18 months, yes.
I don't know how long these measures are going to be needed for. I think the modelling so far suggests that it's certainly not a couple of weeks. And one of the things that I think, if you look at some of the approaches that have been taken, the assumption that you might just close things for 2 weeks and start up again is not correct. It's going to be months. I don't know how many months. It's going to have to be data driven. In other words, as you see things changing, you might need to do more, you might need to do less, and by the way, that might happen quickly. just as it did over the course of the last week.
Yeah.
That isn't because there's a sudden change of strategy, it's that you're responding to the information you've got in order to change, and that's what we need to be prepared to do. And I think we're going to have to be equally nimble as we think about backing off again. And we're going to have to try it. And one thing is, for sure, we haven't got immunity to this virus, and therefore, as we back off, it may come back again, and we're going to have to manage that very carefully. And we're going to have to hope that we can get through quickly with some of the other interventions as well to try and get on top of this, so vaccines and the other approaches that are being taken, which I have to say, I think there's been really remarkable efforts and progress in some of those, but we're still a long way off.
And in your conversations internationally about countries that are further ahead than us, do you have an idea of what their plans or what their approach is going to be to actually lifting the measures? For example, potentially China.
Yeah, not really is the answer. I think everyone's asking the same question, and you look at some of the scientific papers coming out from China and elsewhere, people are looking at what could happen, but we don't know yet. And I think all of the evidence from previous epidemics, and this type of infection would suggest that you can't avoid this bubbling back up again when you lift off. So that's what we're going to have to be aware of, and that's what we're going to have to try and manage.
And when you say bubbling back up again, do you mean a spike, or this being something like we would understand as seasonal flu?
Well, seasonal flu is, in a sense, a spike every year, and that may be what this ultimately becomes, something like that, and that may be what we need to plan for. So there are two ways that you can think about this. So I think if you withdrew all of the measures immediately, you'd probably have a lag phase and then a peak. Mm-hmm. If you withdrew some of them, you could begin to sort of see, is it just sort of creeping up, and you're beginning to see an effect, and you might then reimpose them. So I think that's why I refer to sort of an agility in managing this is going to be quite important, I think.
Thank you.
I've just got a couple of questions from our colleague James Murray, who's not able to be here. But I wonder if I could just follow up on one of Laura's questions there, because I think the thing that's puzzling people who look at other countries, China officially announced they think they're past the peak. South Korean Foreign Minister was on TV at the weekend saying that she thinks that South Korea has passed the peak, and they seem to think they passed the peak with less than 1% of the population being infected. And they're very realistic. There could be second waves, third waves, but they don't seem to be expecting it as much as you do. And I was just very struck by the phrase you said just then. You said if you look at all the evidence, you can't avoid concluding that it's likely to come back. And I just wondered if you could explain to non-scientists, because I think the Chinese view, the Korean view, seems to be that it could be something like SARS, for example, which just burns itself out when the reproduction rate gets below 1. Why is it that you're unfortunately so certain that it will come back?
So I don't want to be a merchant of doom on this, but I think the transmissibility of this virus is very, very unlike SARS. I mean, SARS was not transmissible in the same way as this, and it had a very high mortality rate. This has got actually a rather lower mortality rate. It's got a very high degree of mild infection, and just today there was a paper that I was reading from China suggesting that something like 86% of the infections in Wuhan were not ever detected before at the time. So there's a very high degree of transmissibility. All of those characteristics, from the evidence from everyone we've heard from, suggests that when you lift, you're going to get something coming up again. Now, I can't tell you how big that's going to be, and we may be lucky and maybe it doesn't, but everything suggests that that is what you would think in an outbreak like this, with a virus like this, with the sorts of properties, would be what you would expect to see.
Thanks. And then I'll come to you in a sec, but I just got a couple of questions from...
And by the way, I hope they're right and it doesn't. I mean, that would be a perfect outcome, and like all scientists, I'm very happy if I'm wrong on that and it doesn't come back.
So these are from James Murray. His first question is, more than other countries, the approach in this country continues to segment the population with different levels of isolation. Could you explain very specifically why you've chosen this route rather than more blanket approaches with reference to scientific evidence, behavioural science, economic interest and so on?
Well, we've said everything's the same for case isolation, everything's the same for household quarantine, asking people to stay together in the whole household. We've given the same group of social distancing measures for everybody and said everybody should take those seriously. They are particularly important to be very stringent about them if you're over the age of 70 or have another illness. And then we've taken one group of much more vulnerable people with serious illnesses that can predispose you to viral infections and to other things where there will be specific advice. And I'd be surprised if people like that weren't getting specific advice in other countries if you're particularly susceptible. So I think we've gone for pretty similar, actually, advice across most of the population.
Okay. And just to be clear, because there was a bit of debate about this yesterday, for over 70s who don't get contacted by the NHS as being someone with a long-term condition that makes them especially vulnerable, could you just explain what sort of changes in their lifestyle you're hoping for? I think perhaps the easiest way to do this is to say, what are the kind of things they might do now that you're asking them not to do going forward? These are the healthy over 70s.
Avoid crowded spaces, avoid gatherings. Don't go to the club that you normally go to where everyone's sitting around together. Reduce travel. Try to avoid unnecessary travel. Don't go out to do your usual things in terms of going to the shops and things unless you absolutely have to. So if somebody can deliver it for you, so much the better. And so there are several things they shouldn't do that they're doing now. What Chris Whitty has said, and I think it is an important point, is you could go for a walk around the garden, or you could go for a walk avoiding close contact with people, so that we're not asking everybody to be completely separated. But there is quite a big change that's being asked for, and the specific guidance is on the DHSC website.
But just very specifically, what about going to Sunday lunch with their family and their grandchildren? Yes or no?
Do it.
Shouldn't?
No.
Okay. Yes, I've just got one more from James Murray, and then I'll come to... Oh, sorry, on that point. Yes, please do.
Just on that, exercise is going to be key. So are you saying, when you mentioned about walking in parks and so on, is that the sort of thing where if someone wants to go and play golf, or, you know, the sporting exercise that they can do en masse, but where they're not close together, they could still do?
I think the advice is to try to avoid close contact, is try and reduce social contact. I think realistically, a walk is okay if you're keeping a distance, but it's not if you're going to be in close contact with people.
So realistically, it's possible that over the coming months, healthy people over 70 could go out to parks as long as they're keeping away from each other, effectively. So they could do group exercise, but be two.
Well, I don't think group exercise. No.
No. Okay.
So I think again we're straying into into areas that are very much sort of NHS advice and DHSC and the CMO advice. But I mean, I think this could go on quite a long time. I think it's quite important that we get it right. And the danger is in crowded places, gatherings where you've got a few people in a enclosed environment. Those are the sorts of things that we're saying don't do. Don't go out to the shops if you don't have to. Really make sure you do it only when it's absolutely essential. There's no other alternative. And I'm afraid it is avoiding those sorts of social interactions which are such a crucial part of everybody's life. I'm afraid we're asking us all not to do that.
Sure. Thank you.
And then a final question from James Meyer. This is slightly touching on what you've said before, but I just want to ask it because he's asked me to ask it. Given that the advice is slightly different for the under 70s and the over 70s, does herd immunity and the concept of herd immunity play any role in the thinking with respect to that slightly different advice?
Oh no, I mean, in fact the advice is the same, it's just saying do it more stringently for the over 70s. And the whole point about the over 70s and the vulnerable groups most of the measures we're talking about are about trying to protect everybody. They're about trying to prevent the spread of the virus in a way that puts people at risk. For the elderly and vulnerable, it's about protecting yourself. So it's a rather different set of messages. I mean, clearly it's also part of the first message, because they're not spreading it either, but it's very much about protecting themselves.
Thank you. Luke.
A couple more questions about evidence, if that's okay, particularly around medications. So a week ago, common blood pressure medications, things like lisinopril, ramipril, candesartan, a lot of people are on them. There was some concern that there could be a problem there. Yesterday, France announced that there could be a problem with ibuprofen, and the BMJ, you probably won't have time to see it today, have produced an article today saying avoid it. I wonder if you could comment on the evidence around both of those and whether you think that's advice. I appreciate we're straying to medical advice.
Yeah, no, it's fine. I mean, I can talk about that from a sort of scientific perspective.
Please.
And I spent quite a lot of my life trying to make drugs and making drugs, so I do know about that. But I think there's theoretical reasons around ACE inhibitors which are quite interesting, but I don't see strong, compelling data yet to know what the answer is to whether that's real or not, and that's being looked at. And the ibuprofen example, again, it may or may not be right, I don't know, but the sensible thing to do, I think, would be to say, well, don't take it at the moment, take something else, paracetamol or something.
Yeah, thank you. And one final question. What surprised you the most about the situation we're in?
Well, I don't think any of us have seen anything like this. I mean, this is a first in not just a generation, but potentially the first for 100 years. And so none of us have seen this. It's not like an outbreak of something like Ebola, where it's a very different type of disease with a very different type of death rate and a very different set of criteria around it, circumstances around it. This is a daily changing, unique situation where we're learning as we go along. We're going to have to invest heavily in science. We're going to have to research hard to find out why some people are getting ill, the real illness, why some people have a particular cytokine storm, why people get better quickly in some cases, what the vaccines are, what the tests are, what the treatments are. I mean, this is a really big, intensive research effort. And so what surprises me most, it's that, you know, as always in medicine, you find out there's a lot you don't know.
Thank you. Yes, Steve.
Sorry, I just wanted to come back on the data question. We talked about modelling and so on earlier. Just occurred to me from some of the comments you made around the use of data for public information, but also the collection of data. Testing is one thing, but also making sure we're doing the right research relies on the right data being collected. I just wondered whether any conversations have happened with places like Facebook and Google and so on to enable people to track their own journey when they've got it, as it were, in terms of the illness, and also whether you're looking at data from, say, hospitals or local areas where they can say, look, we're nearly full, so that people can see the capacity that's going on, so that it's a shared data and there's a responsibility to share that data.
So three things on that. First is that the research community, I think, has stepped up really quickly to some of this, so that we've had meetings which I've called every week or so with UKRI and the Research Fund as Wellcome Trust and so on to try and get money out of the door quickly to get this going, and that's worked really well, and those organisations have worked brilliantly there, I think. I think the tech companies are all over this for the reasons you said, and they've been talking to government and to other governments about how we can do this. And yes, absolutely, the data flows of what's happening locally are going to be critically important to understand where NHS capacity is filling up, where there's an outbreak that's got a bit more, where there's one that's got a bit less. And I said yesterday, you know, London's ahead of the rest of the country in terms of where it is on this outbreak at the moment. Mm-hmm. Others will catch up, and we'll see it in different times at different places. We need to be able to get the right data flows from the NHS, who are working incredibly hard on this, and Public Health England have done an amazing job on their activities so far to make sure we get that right to be able to monitor this properly.
Thank you.
Any other questions? On which note, thank you very much for sparing the time, and thank you for your valiant efforts. Much appreciated.
Thank you.